Okay, hi. Good morning, everyone. So today is a panel for rectal cancer. I think over the last year or so, with so many trials coming in, I think there has been a lot of forecast and everything is changing now. So what was right a year before last is not so right now. And there's now always a tussle between medical oncologist and radiation oncologist who is going to go first. So I'm going to discuss some common scenarios and see where we go from there. I'm Dr. Saklani. I'm a colorectal surgeon. But I don't know all of you personally. So, but I think we'll take that. Okay, so I'll share my screen.
This is a very heavy radiation oncology dominated panel, sir.
Okay, right. Can you see me?
Yes,
Can you see my screen? Yeah, okay.
Yes.
So I think we'll go straight to the point. I think the rectal cancer, most of it in India, about 60% is locally advanced rectal cancer, 25% is metastatic. And then early rectal cancers are relatively less, almost 3% or so. So I think with the panel is on MDT, so we're going to discuss some common scenarios, which everything is, there are so many ways of doing it and you may not be right or wrong. So we see a 60-year-old male, quite fit and well, complains of bleeding PR, change of bowel habits. The tumor is 4 centimeters from the anal verge. Colonoscopy is normal. Biopsy has moderately differentiated adenocarcinoma. An MRI showing it is just confined to the bowel wall. It's about 4 centimeters. It looks like T2N0 with no other metastatic disease. So for the panel, I would like to ask if there's any surgeon. I know Dr. Haribhakti is in there. So would you like to do any more tests? It looks like T2N0 on MRI. Would you like to do any more tests for this one? You've seen the image before.
Sir, intersphincteric space is free, I think. Yes, it is free. It is, this MR is okay, sir. And CT thorax upper abdomen serum CA, if it is T2N0, EMVI is negative, and we can get away with good CRM.
Hello, Dr. Saklani. Hello. Hello.
Dr. Kinjal, you can proceed. I think so. Na? Meanwhile, Dr. Avinash will join, maybe.
So I think he would have some questions to ask to the surgical team first, and Bharat has rightly mentioned that, this patient looks to be operable lesion. He can get a CRM negative. So I think he would have some further questions to him.
Yeah,
Can you hear me? Okay, now I can see you. Okay, it's a different one. Sorry. Just give me a minute. Hello, can you hear me?
Yes, sir.
Okay, sorry. Okay, so I think this is a panel discussion on rectal cancer. My first case is a 60-year-old male, 4 centimeters from the anal verge. Colonoscopy is normal. CT scan shows no metastasis, and MRI rectum looks T2N0. So would anyone of the panelists from the surgeons, would they like to do any more tests for this one other than MRI?
No, sir, MRI is fine.
Sure.
Good quality MRI is fine.
Okay. So how would you approach this patient? So it looks like T2N0, 4 centimeters from the.
Yes. CRM negative in EM, there is no EMVI and it's M0. We can get good CRM. We can do the upfront surgery also.
Okay. Is there anyone in the panel, any other surgeon? Dr. Haribhakti, I know is not there. Is there anyone in the panel who would like to disagree, or what about the medical oncologist? Yeah, go on.
Yes. So, Avanish, this is a very challenging scenario in terms of 60-year-old gentleman with lesion starting at about 4 centimeters from the anal verge. T2N0, I mean, if you are asking if I want to do anything before taking this patient for the next action, maybe EUS, just to make sure that I'm definitely not dealing with any node in the surrounding. And then next is, of course, surgery. If I'm going to take this patient for surgery, then at 60 years, I want to check the proper anal tone, his sphincter, how good it is, because I'll be confronted with whether I can do ISR in this patient or not. I think this is
that's a great point, Dr. Kothari, because that was exactly I was thinking. So it looks like T2N0 CRM free for the 63-year-old, and it will definitely end up with an intersphincteric resection. So there are so many options here, and so always this one. So, but we know over a go on, man.
Yeah, it is 4 centimeters from anal verge. If the patient is going to have permanent colostomy at 60 years of age, then definitely we would like to discuss the options of neoadjuvant CTRT plus minus surgery. Or if the patient is very frail, we can go for, though not recommended, but close observation if a very good response of NACTRT, and if the sphincter is going to be we can be salvaged, sphincter can be salvaged in 6 years of age. Because it is 4 centimeters from anal verge.
Sure. So Dr. Kothari, now your medical oncologist is thinking he's 60 and his functional outcome may not be good. He may end up with a permanent stoma. So how would you take it? Because this is the challenge now. You have this thing, the patient is there in between. You can operate, they can give chemo radiation. So what do you think would be the right thing? You are taking this group in charge now.
Yeah, so Rahul, we are still debating about the sphincter preservation. It is possible
that
I
said, sir, this is not the acceptable and not the recommended guidelines. That for making a surgery in which we are going to for salvaging the sphincter in a low-lying early tumor, if by surgery we can, if by giving neoadjuvant treatment we can salvage the sphincter, there are no guidelines that you should do it. But most of the time, practically, we see that because the quality of life also matters. If it is 100% colostomy is going to be permanent in such case, then would like to discuss with the patient options of neoadjuvant CTRT with a very good option, with a very good CR and very close observation, whether he wants to avoid colostomy or not. Side by side, also explaining the thing that it will be a little less oncology outcome will be there if we are avoiding surgery.
Okay, let's go to Rashi. Rashi, what do you think? If you were going to give some sort of neoadjuvant treatment for this, and how would you cancel it? Because NCCN guidelines would not say giving chemo radiation for this one. And what do you think would be the response rate?
Yeah, actually, Dr. Rahul is saying rightly, but what I have seen in my practice, in most of the patients they require surgery. And so the benefit of giving radiochemotherapy, it's.
I'm not saying we will give neoadjuvant CTRT, but we'll have to discuss that if there is 100% chances of a permanent colostomy, and if the patient wants, with both the options explained, that surgery is a better with the oncological results. But yes, we can take a chance, because permanent colostomy, living with the colostomy, many patients will not agree.
Sure. So Rahul and Rashi, so suppose for T2N0 were you to give chemo radiation, because this is interesting, because that's how things go across. So suppose the way you want to give chemo radiation, what are the chances? Because you are thinking by chemo radiation, you don't want to downstage. You want to have complete response and have wait and watch sort of thing. Is that what we're looking at? So what do you think the chances are for this lesion to become complete response? And suppose if you think for wait and watch, these are all theoretical things. Finally, it comes down to patients. And what would you think? Any idea? Or
so practically we can say the patient that 30-40% chance will be there.
Okay, that's right. So I think the first thing is the tumor is 4 centimeters from the anal verge, and if the sphincters are free, like
that is a very bold statement. 30-40% is not, any study has not shown that there could be a CR, clinical CR. You can't achieve 30 to 40% with neoadjuvant chemoradiation, no matter how much you would give. At best, people have achieved 15%, you know. The
Sir,
volume
I am
reduction,
advocating, advocating this approach only when the sir asked what are the different options. I said this. I am not saying ki I will go with this.
Okay.
But if patient
Okay, I
wants
think we'll
sphincter to
move
be
forward.
preserved only, then I will offer this. And
That's
I'm
right.
saying this is not a oncology. Results are better in a surgery. This is not a advocated option, but practically sometimes this is an option.
Okay, that's
not
good.
recommended from my
Let's come back, Rahul. Okay, let's come back to this again. So, but most importantly, like Dr. Kothari said, the thing. Initially, for 4 centimeter people who had done abdomen, you can do TA, TME, and you can save the sphincter. So, and these are the sort of things. So, when you see a coronal section, you will see sometimes tumors which are here, intersphincteric space is free, and intersphincteric resection can be done. If, however, it touches the levator, then probably requires an APR, and then you have to counsel. So these are Rullius classifications, so we'll forget that, and then we'll go to the next one. So this is not a new thing. Intersphincteric resection has been there for quite some time, and I think being done all over the country now. The most important thing is the concept of distal margin. So now even for 1 centimeter, we have found follow-up local recurrence rates are quite acceptable, so you can save that. So it doesn't require an AP resection, but at the same time, you have to look at functional outcomes as well. And about 10% of them, the functional outcomes may not be good, but it requires support from the nursing thing, rectal irrigation, and things like that. So for 60-year-old, it may not be a bad idea. We have looked at things, and it is acceptable, but some people can have bad outcomes, and those people may require a stoma. So on the whole, surgery can be done. So I agreed with Dr. Kothari. We discussed with the patient and we did a robotic intersphincteric resection. It was T2N0. But coming to Rahul and Rashi, so look at the other option. So this was a study from Lesos. This is very old study, 2008, and surgical endoscopy. For this T2 rectal cancer, they gave chemoradiation and did local excision after 8 weeks or so. And in the other group, and did TM. Very small number of patients, 35. And in their series, the local recurrence rates were low, so 5.7% in this one, and 2.8% after TM. But this has not been reproduced very often in many other studies. The survival for rectal cancer was similar. So this was a study by Lesos, where said they could give chemoradiation, downstudied, and do a local excision. There's another study called TREC, which has come out, which looked at the same thing, but instead of long course, they give short course radiotherapy and operated after this. The cases were T2 or T1, and they looked at it. But if you look at the outcome wise, for even for these early rectal cancers, they were able to save the sphincter in 70% of the cases, or organ preservation was there in 70% cases. But then if you look at it, there is a difference in DFS and OS for these things. So they are looking at larger numbers called Star Trek study, where they can think of local excision. But in this study, the staging was not very good. It showed that maybe 50% could have a complete response or so. But overall, the outcome didn't look very good. So on the whole, for older, unfit patients, this can be tried. If you were going to offer wait and watch, then you would say 50% people may at the most respond and go on wait and watch. But for the other 50 patients, you're given chemoradiation. And if you do intersphincteric resection later, then the functional outcome could be poor. So we have to be careful. So we have to counsel them. They may have additional radiotherapy. And if you were to offer T2N0 to young patients like 40 years chemoradiation, then they're looking at second primary. The second primary rates may be as much as 20% at 20 years or so. So very difficult one. So Dr. Kothari, what do you think finally at the end of the day? Was your decision right, or which one for this T2N0?
Yeah, if I'm able to do ISR, probably I'll continue with that. Now, T2 scenario, I would further probably would like to look at if it is a posterior lesion and where I may be comfortable doing the local excision, what you have shown in one of the results, then that could be one of the options that one may consider. But otherwise, if it is a circumferential long segment lesion, then
Sure.
if the surgery is a better option.
Definitely, definitely. Okay, that's great. That was a great discussion, and that is how it ends up. Sometimes now, it can be a bit this one. Okay, let me go to the second scenario. It's a 45-year-old lady. It's a locally advanced upper rectal tumor with liver metastasis. They look resectable. They are there on segment 2, 4, A7, and 8. The rectal cancer looks locally advanced. So, any other radiation or medical oncologist? So, what would be your choice for this one?
Sir,
How would you treat this? Locally advanced? Go on.
There is a locally advanced with metastatic liver lesion.
Sure. So how would you treat it? It looks like potentially resectable one.
So we should start with neoadjuvant chemotherapy. We can go.
It's a liver metastasis is there. I will go with neoadjuvant chemotherapy first for initially 2 months of cycle. Then I will reevaluate the disease, whether, because there may be 4-5% of the patients which may not respond at all to chemotherapy. There is increase in a liver metastasis or a development of lung metastasis. That are the very bad patients. Otherwise, it is a responding disease, or if the liver metastasis comes down or in a chance shows very good response, then we can discuss the further options, giving RT and surgery in such patients. If they are responding, we will also escalate the treatment.
Yeah, I agree. We should start with chemotherapy and then reevaluate what should we do further.
Sure.
Rahul, what happens if there is a complete response to chemotherapy for liver lesions? If liver lesions are completely gone, Rahul?
Yes. If liver lesions are completely...
Yeah. So now the question, like the reason I asked you this question is because if there is a complete response to neoadjuvant chemotherapy to the liver lesions, what would you do to the liver then?
See, she's a fit patient, 45, hypertension, diabetes can be managed. I will give neoadjuvant FOLFIRINOX for 3 months. If there is CR in liver metastasis, I would like to go for subject for surgery. And before that, I would like to go for radiation. And in this case, short case radiotherapy from my side will be preferred if you agree. Ultimately, radiation decision will be yours. Yes, but short course RT, complete the radiation fast and do the surgery with the rectum. And if a metastectomy can be done, then both things can be taken care of.
Yeah. So for a metastatic conditions, yeah, we can think of going for a short course. Yeah, when there is a metastasis, yes.
Yeah, I agree for short courses.
Yeah.
But for the reason, I think we should put some markers.
That was specifically my reason to ask him this question. So if there are liver lesions and if there are small liver lesions, we can put markers so that we know that, this was the area where the tumor was. A surgeon can answer that, Bharat or Jagdish sir.
Now that the lesions are gone, I go. Yeah. Yes, sir.
Yeah. So, yes, marker is a good idea. But before that, I would like to do the MRI of the liver to really document that how many lesions we are dealing with, and that's very important. Regarding radiation short course to be given or not, probably we can decide in MDT exactly where is the lesion, because if you have given proper neoadjuvant chemotherapy, and if I'm not really worried about upper rectal lesion, where if it is a mid or lower rectum, I'm worried about the CRM. Here I'm not really very much concerned about CRM. So whether I want to add radiation to this patient or not require little further information.
Right, sir.
Yeah.
I guess what the radiation oncologists believe that at least these are the ideal patients for short course radiation. You would definitely not prefer long course.
Samir, but it will depend on the
the location factors. Yes, sir. Location definitely is important.
Yeah.
For mid and lower, definitely, sir. There's no doubt we should consider them for short course radiation.
Okay.
For middle, lower, and if mesorectal nodes.
Yes.
Then we can with short course RT, and as sir said, if it's upper rectum, then you can go with direct surgery.
Yes. Yes, I agree.
how many of you are practicing short course radiation? Meanwhile, Dr. Saklani comes. Dr. Kinjal, you are practicing short
Yeah,
course
so,
routinely?
so at my place, Samir is taking care of GI.
Mhm.
So Samir would be able to answer it better.
We have recently started adopting to short course regimes. Of course, we select our patients, not all patients, especially if they are lower rectum, and that too when the disease is going anteriorly, we try and avoid. When the patients are having lateral nodes, we try and avoid. But all other patients we can consider for short course. Recently, we have taken in past 2 months, we have taken 3 or 4 patients for short course radiation.
Though we both are believers of long course,
Yeah.
but yeah. So
Yes.
that is the answer to your question. That we would definitely prefer a long course compared to short course. But yeah, we have started recently now.
Actually, what I discuss with my surgeons, if you want response, if you want, so you have to wait for at least 2-3. You should go for long course RT, and after that we have to wait. But
Yeah,
if
so now,
if the situation is like that, as Dr. Saklani has presented, liver mets are there or higher nodal burden, then we want, yes, we can go for that neoadjuvant chemotherapy, then short
yeah.
course RT.
Yeah, so
Let's say
the thing is,
in
my friends in
non-metastatic-
US, I have discussed with my friends in US, and Rahul can comment on this. The trend towards the TNT. I think Rahul, you can take it for the TNT, total neoadjuvant therapy.
Yes,
So many of my friends in US practice that. Rahul, you can take it, I think.
like sooner or later TNT will be accepted modality.
Yeah.
Sooner or later TNT will be given in all T3, T4, node positive. SCRM is this mesorectal fascia is involved in bulky T4 disease and in this type of metastatic disease. See, 45-year with 1 or 2 or 3, 4 even metastatic lesion in the liver, they can be treated with curative extent, with a curative intent. If adjuvant chemotherapy, like in colon cancers, many of the patients they survive for long even if metastases are there, but is all these subsets, as I said, metastatic tumors, T3, bulky T4, mesorectal fascia is involved, nodal diseases there, especially N2 N3 disease, go for 3 months of neoadjuvant chemotherapy, then go with RT. And RT, as we have discussed, that if it's a lower and middle with nodes are there, then preferably go with long course RT. Otherwise, preferably go with short course RT followed by surgery. I think this may become the norm in next 2 to 3 years.
Or the other way around, or neoadjuvant chemoradiation followed by the further chemotherapy and then the surgery. Either of the ways.
Yeah, because the debate is like the thing is that you require around 6 to 8 weeks after radiation for the best surgical results. For one approach is like you give CTRT, and in the meanwhile you are waiting for 6 to 8 weeks. You give some chemotherapy at that time, so that your pathological response also gets better. Surgery becomes easy, and you get the maximum local response. And so for this waiting of 2 months, you give new chemotherapy, so systemic disease will be taken care of.
In fact, can I have a question, especially to my radiation colleagues and the surgeons in our panel? So, what is the importance of clinical examination in these patients? Because recently we have a patient, me and Kothari sir, the MRI was showing something else. We both examined the patient clinically, and somehow our plan of the whole management changed. So what is the importance of per rectal examination in these patients? Especially, I'm talking about the lower rectal cancers.
Clinical examination can never be replaced. Can never be replaced with any imaging devices we have. Examination plays a very important role in any malignancy, in fact, for that matter.
Yeah. Because in the case capsule, initially when the MRI and the things were discussed, we probably missed the importance of clinical examination. Recently, me and Kothari sir saw a patient, MRI was showing it was looking at T4B, but when we saw it clinically, the MR which was showing that it is adherent to prostate, clinically it was not. And initially we were thinking of giving long course, but then we changed it to short course because the disease clinically was not that bad. So what is your experience? I would like to ask our surgeons as well.
Per rectal examination is the most important part in the rear rectum. Generally, good quality MR, good quality contrast MRI generally match up with the digital rectal examination findings. Generally, they don't differ. When much of jelly is given when doing MRI, the distance may vary 1, 2, or 3 centimeter, but otherwise it generally matches with good quality MR is there. There is discrepancy between the digital rectal examination findings and colonoscopy findings.
Yeah,
It is prevalent in general scenario, but generally good quality MR and digital rectal examination they match up.
definitely. Rahul bhai, I have a question for you. How do you choose your patients for TNT? Do all patients require TNT, or you will select your patients?
Samir, right now recommendations say many of these all subsets T3, T4 node positive, any node positive. But right now I am or as a team we are going for in N2 disease, N3 disease, and bulky T4. Otherwise, right now though recommended, but T3 and N1 nodes most of the time they are going for CTRT directly. But with time, all will agree that they will go for TNT.
So bulky nodes and N2, N3 disease. Yeah, you're right.
Yes.
And maybe a metastatic condition to liver.
Metastatic, of course. Yes.
Yeah.
Where is our captain, Dr. Saklani?
I think he
has some technical issues.
Some technical issues. Yeah, that is what I was feeling. That maybe technical issues.
So maybe, sir, you can lead what?
Yeah, you
what
can. I think you can ask a few
Yes.
questions.
Yes,
Maybe you can make a case in your mind and you can just ask questions.
Okay, at least somebody should check. Ravindra, please check where is Dr. Saklani. He's seen here actually. So he is.
Oh, sorry. I'm still here, Dr. Kothari. Okay.
Yes, sir. Please.
Right. Okay. Okay. Let me go back to
Sir,
share content.
Please don't leave us behind.
I thought I was on. Okay. Let me see. Okay. Let me go back again and see where we are. Okay. So for the last case, obviously you won't give long course chemo radiation. You'll give short course you'll give chemotherapy and assess, or you can give short course radiation and chemotherapy, and then you will assess. So we'll go back to TNT again. Can you hear me, Dr. Kothari?
Yes, we can
Yes,
hear.
sir, clear.
Okay.
Yes.
So let's
loud
come
and
back to the next one. We got a few cases to cover. So this is a lesion 6 centimeters from the anal verge, BMI is 21, tumor 5 centimeters from the anal verge, T3 and 1 CRM negative. So now this is the one, maybe call it T3C or so. So you want to give neoadjuvant chemo radiation. So there are a lot of options available now, and then people can kill each other just by deciding what is good or what is not. So let me go through the options. So this is like a lesion which is there, looks slightly bulky. The stapling may be difficult, so you have to give some sort of chemo radiation. So this was the standard thing we were doing. SOVR, giving chemo radiation did not improve survival, but local recurrence fell down from 13% to 6%. Then it came the Butko trial, where they showed having a short course radiation and 3 cycles of chemotherapy. In fact, they found overall survival was better at 3 years, but there was no difference in local recurrence. Now this Rapido has come. This is for only high-risk patients, T4, N2, MRF positive, UMBI, and they found there is no difference in overall survival. But the DFS and metastatic free rate is better by 7.5%. Local recurrence is slightly on the higher side, 8.7% versus 6%. And top of that, then you have this Prodigy 23 trial, where people are giving 6 cycles of FOLFIRINOX before for all cancers, locally advanced, not the rectal cancer. And then they give chemo radiation. So duration of therapy 6 months. And again, DFS and metastatic rate is better by 7.5%, but more difference in overall survival. They all say complete response rate for both this TNT is double, but it doesn't translate into overall survival. So now let me come to all of you at a time and say, let me come to Rashi first. So Rashi, what would you think for all these 4 things? And then we'll come to surgeons. So you have to look at all these things, whether the aim is either to improve overall survival, either increase complete response rate, or you want to, so duration of therapy has also got to be acceptable.
Yes.
Plus the effect of things like FOLFIRINOX or 6 things. So what would you prefer? Let me ask, because it's going to be different. People are killing people across the country, giving TNT and things like that. So, and then who's going to make the choice first? That is another thing. If it comes to medical oncologist, he may say TNT, surgeons may say surgery or CTRT. So let me come to all of you. Let me come to Rashi first. Rashi, what would your preference?
Yeah, actually, we have discussed these type of scenarios, and this case is T3 N1 nodal burden is not very high, so we would like to give as of now, long course of radiotherapy with chemotherapy. And what we have seen with FOLFIRINOX, that trial, FOLFIRINOX is having a lot of toxicity. Our Indian patients are not able to tolerate, although Rapido is good. But in this patient, nodal burden is not very high. So I would like to go first with RTCT, long course, followed by 6 to 8 weeks gap surgery and chemotherapy. This is
okay.
my
Let me stick to Rahul. What is your option? Okay, let's not kill each other. So just tell me what would you want to do?
Okay. Sir, first, FOLFIRINOX is not that bad. It is tolerated well in a fit patient. Right now, for T3N1, I will go with the long course RT with capecitabine, followed by surgery, followed by 4 months of adjuvant chemotherapy. And T4N2 disease and metastatic disease, I would like to go with Prodigy like something. 3 months of FOLFIRINOX, surgery, and then adjuvant 3 months of treatment.
Okay, that's not a bad idea. Why would you not want to go for Rapido? Because that was mainly for higher risk. Prodigy was only for all patients. And you have to realize in the difference in the study, they say complete response has increased 15 to 28%. But upper rectal cancers are not candidates for organ preservation. They are not candidates for wait and watch. So just having complete response means they are going to go for surgery. So whether would you want to increase the duration of therapy, but difficult to know. Dr. Kothari, what would you say?
Yeah, so I would, in this N1 scenario, chemoradiation and surgery is all right. If it is N2, I have other concern about the metastatic disease developing and FOLFIRINOX in a young patient. We have also considered giving in some of our cases, otherwise straightforward here, neoadjuvant chemoradiation.
Sure. So in for all the radiation oncologists, because of COVID, there's been a problem now. Sometimes people don't want to stay 6 weeks in the hospital. So have they changed over to any short course protocol? And if they are they using the Butch course, short course with 3 cycles chemo, where overall survival is better and local recurrence are comparable, or even the Stella 3? Or do you want to go with Rapido with 6 cycles of chemotherapy along with SCRT, where local recurrence is high slightly, but no, DFS is slightly improved. Who else is there? Is there anyone else other than Rashi and Rahul? Sorry.
So this is Kinjal. I would also
Kinjal.
prefer, so I would also prefer what they've said, that, we would go for a long course chemoradiation in this patient, followed by surgery, followed by the adjuvant chemotherapy. And I think Dr. Sanjeev has joined. So, he can, take it further as a surgical colleague.
Okay. Sanjeev, T3N1, we want to give new. Oh, Dr. Haribakti, good to see you. I can't see it. So now we are just looking at a thing. There are a lot of options available, Rapido, Prodigy. So this is the sort of tumor T3N1.
Right.
And the lesion is 6 centimeters from the anal verge.
Right.
So you are making the decision. So what sort of neoadjuvant therapy would you want? Chemo, radiation, short course RT chemo, or any of the TNT studies?
I think the literature is not very clear on this subject. What we follow the protocol is, one is we look at the location of the tumor. If it is a lower rectal tumor, definitely it is a high risk location, number one. Number two, the extent of the tumor invasion, T3, T4, and even in the T3 now, there is some evidence to suggest that extramural infiltration of more than 5 millimeters has a higher rate of local recurrence. And disease, we'll also like to look at whether it is N1 or N2. This is the clinical staging, though we know that clinical staging is not the perfect staging, but at least with the current modalities, it gives us a good idea of the clinical staging. So in terms of a T3N1 located in the lower rectum, which looks like a bulky disease, I would prefer a long course chemoradiation in this patient. However, if the same tumor is a little higher, and if it is just a T3 or a, N1 disease, then maybe even a short course radiation could be a good option in selected patients, especially when it is in the upper rectum. We could go for a short course radiation and go for the straightforward surgery and then finish the chemotherapy as in an adjuvant setting. So I think these are the ways. If it is an N2 disease or a T4 disease, definitely long course chemoradiation is the preference. But for a T3 disease with N1 or N0, I think short course radiation is an option. And the studies and the trials have shown equivalent benefit. Even if you see the Europe, everybody uses the short course chemo radiation or chemo radiation. And nowadays they wait for a little longer before they operate. But even you could operate after 7 to 10 days after a short course radiation. So short course radiation is a good method. Selected patients, I think it's it's a much more patient friendly method. And you could of course do the adjuvant chemo after the surgery, and you could get an equivalent result by this
Sure,
method.
sure. So Dr. Haribhakti, I like you very much. You are a surgeon. Exactly. I love you. So anyway, so this surgery, you give chemo radiation, it has shrunk down and you want to do surgery for this one, 6
Yes.
centimeter from the anal verge. What
Yes.
would be the approach? You are a great laparoscopic surgeon. I think you are also like doing TME. So what would be the approach in this patient?
Yeah, so this approach will depend on the digital rectal examination. I think that's a very key test, used to identify the location of the tumor, its location from the anal verge, and its bulk of the disease, whether it's anteriorly, posteriorly, whether it is a fixed disease or it's a mobile disease. And after the neoadjuvant chemoradiation, we like to wait for at least 6 to 8 weeks. That is our protocol. But currently, people wait even up to 10 weeks before going in. So we like to see the tumor downgrading also. We like to see the MRI after the tumor downgrading and see the involvement of the sphincters. Most likely with a 6 centimeter disease, I don't expect any involvement of the sphincters. I believe that we could, get a good distal resection margin and do a laparoscopic TME. If the tumor is very bulky, then for such a low tumors, it is very difficult to get a stapler across, go down below and get it across. And in such patients, a combined approach with the laparoscopy and a transanal approach is a very good approach currently used for this kind of disease. It may not be a complete TME from below, but it is like as much as you can do from laparoscopy from above. You dissect the mesorectum as much as you can go, and then you can convert from the transanal approach and do the part of the dissection from below. And this is a good method for obese patients who are male patients and who have bulky disease, low rectal disease. For these patients, it's a very, very good approach. Even a robot cannot get us down below the laparoscopy because there are some structural limitations of the pelvic bony structure and the angulation of the staplers. With the laparoscopy or even the robotic staplers, they cannot angulate beyond 60 degrees. And these are some of the technical limitations that are encountered. Either it is a laparoscopy or a robotic platform. And that's why the transanal surgery is a much better option in such selected patients.
Sure, Dr. Haribhakti. I think you are an avid trainer, and I have also seen you trying this out on animal labs and cadavers, and you worked hard on this. So it requires a lot of training and proctorship. Oncological outcomes are being evaluated in RECA 11 and Color 3. There have been some complications that people have done it without any training, and they can have CO2 embolism, urethral injury. In fact, there has been people have said you have to do it only under studies, and there is a thing in Europe and this one.
Right.
But I think so it requires a lot of proctoring and training. Thank you, Dr. Haribhakti. So this underwent TME, he was okay. But we are also looking at very carefully. So let's come back to our next case. 36-year-old females, anal disease starting 2 to 3 centimeters from the anal verge. Also bulky long segment disease, loss of fat plane with the uterus. You can see these are not very uncommon in TMH. So it looks bulky T4 sort of thing. I think this is a slightly older case, so we had given chemo radiation, and the patient comes up at 6 weeks and there is no growth palpable. We did a flexible sigmoidoscopy, and again there is nothing, looks completely okay, and MRI shows only fibrosis. So any surgeons, what would you want to do for this one? Initially it looked like it was T4, starting from a long segment disease, and now the disease seems to have disappeared completely, not seen on either endoscopy clinically or on MRI. Is anyone in favor of wait and watch? Or?
So, Avanish, I think wait and watch is currently an option only for very selected patients in multidisciplinary settings. Even in the 2020 NCCN guidelines, they have included this as an option, but it's not the standard of care. And that's what we have to make to the patient very clear. considering that she's a young lady, considering that it's a very low tumor, which was about 2 or 3 centimeters from the verge to begin with. Obviously, this would require an ablation of the sphincters. And that's why I think, we need to discuss with the patient how their compliance would be for a very regular and a close follow-up. That is number one. Number two, whether there are any high risk factors in the histology that could tell us whether there is a higher rate of recurrence in such patients. And if the patient is willing, but I think this is a young patient, and if currently the standard of care would be to go ahead and do the procedure, and that is something that we need to very upfront tell the patients.
Sure. Kinjal, you are a radiation oncologist. You feel it's very good response to radiotherapy. There's no disease. Do you think wait and watch? A surgeon wants to operate and you want to think it should go for wait and watch?
No, absolutely not. I would want this patient to be operated because, the patient had a very bad disease to begin with. T4 lesion. This patient is very high likely to fail. So I would definitely be in the favor of surgery for this patient. Maybe if it was a T2, T3 lesion, T2N1 or a T3N0 or T3N1 lesion where we have given chemoradiation and there is an excellent response, we might think of observation for such case. And that too, we have to think that, give option of, surgery to the patient for sure. But this patient, I would definitely convince for surgery.
Okay, Dr. Kothari, your say on this?
So it's an interesting scenario, and a young girl, 36, and had a initially good disease, bad disease, and has responded very well now. Of course, I would discuss the option with this patient about wait and watch and the risk involved into this. But the kind of response that you have shown, if it is a complete clinical response, I would be tempted, because 2-3 centimeters from the anal verge, you say. So my ability to really preserve the sphincter will swing the decision. That's one clinical situation I would like to explore. But if it is going to be APR for this girl, then yeah, I would like to discuss the option. And we have learned tomorrow morning, Dr. Saklani, from China, that we can ask for ctDNA in this patient. It's outside the normal protocol, but yes, this is also one more ammunition we have when we want to do wait and watch for our rectal cancer patient.
Sure. I think it is an option. It has to be discussed with the patient, like Dr. Haribhakti said, careful selection of patient. They should understand the local regrowth can be as much as 20%. They require follow-up for at least 3 years. They can have metastatic rate of 10% even on follow-up. And most important, if the regrowth happens, they need to have surgery, because even after default for wait and watch is there. But this is a possibility thing where if you want to, we were thinking of an APR before. So that is one of the things. This is another scenario where the lesion is 5 centimeters from the anal verge. MRI look locally advanced. We give chemoradiation, and the rate, sometimes when you go on wait and watch, sometimes the radiation oncologists are very keen. So sometimes they may have an ulcer there and they may think, oh, it's almost responding. So 6 weeks, so they may say, okay, come again at 12 weeks and 18 weeks. And once the patient gets used to it, he tends to disappear. So here, there is a difference between complete response, which I showed before, where the outcomes are very good, and near complete, where you have a small ulcer. So choosing wisely is very important. So this one had a small ulcer or near residual disease. MRI didn't show anything else. So it looked okay. But as they followed up over a period of time, you could see the growth coming back again, and there was an ulcer there. Looked quite aggressive then. And then finally, he had to undergo an AP resection. So you have to counsel these patients well. What you don't want to do is put them on wait and watch and they come back with metastatic disease, and there can be difficult problem. This is especially in corporate setting there. So choose wisely is important. This is another lesion 6 to 2. We've got time, Dr. Kothari? I think we've got 1 or 2. We can have a...
I think so. The time's up, sir.
Okay. I think we've had a good discussion then, and that was really quite enjoyable. And that I wanted to show, actually, this is the real life scenario when all passionate people, they're wanting to do their best, the medical oncologist, the radiation oncologist and surgeons. Patient is still the center, there are a lot of options, but it's better to get together a team and provide the good options there. That is very good. Thank you very much, and that's good.
There is a question in the chat box for the surgeons. So I would want any of the surgeons to answer this. So
Sure, I can take it up.
yes,
The
sir.
question is regarding intersphincteric resections. When would you do intersphincteric? How can you preserve the sphincters? I think for this, the best classification based on which we can take the decision is what is called as a Roulier classification. Eric Roulier is a very prominent surgeon from France. He's a fantastic rectal surgeon. They have devised, based on their large experience, 4 types of rectal cancers based on which you can take a decision. For the type 1, which is intrarectal, where there is a good clear, at least a centimeter margin, you can do a ultra low anterior resection and get away. But for the type 2 disease, which is closer to the anal, the external sphincters, then you have to do a partial intersphincteric resection. For the type 3, which is going actually into the rectal anal canal, intramucosal or intra-anal, then you do a total total intersphincteric resection. But here the external sphincters are not affected. They are not infiltrated or not involved. And this very clearly can be seen on an MR and an endo-anal ultrasound. So these are the 2 tests based on which you can take the decision. And for the type 4 disease, where there is an external sphincter involvement, then there is no other option, but you have to go for an APR. And even in the APR now, whether you want to do the traditional APR or the extra levator APR, these are the questions. Based on the infiltration, we can decide. If there is an extensive infiltration in the external sphincters, then an extra levator APR is an excellent technique. It's a prone APR. And for very limited infiltration, I think the regular APR, also depending on the location of the disease, because the posterior locations are better seen in lithotomy positions, but the anterior locations are better seen, visualized in the prone position. So based on the location, we can take a decision whether we want to do the regular APR or the extra levator APR.
Okay, that sounds good. Thanks, Dr. Haribati. That's perfect, actually.
Thanks, Avanish.
Good. Nice one.
Great.
Okay.
Thank you. Thank you, Saklani sir, once again. It was a wonderful to have you, or as always, and many more years to come. And thank you, Haribati sir, for the nice last touch-ups for the panel. Thank you.